So today's topic is bacterial lobar pneumonia. In this chapter we are going to study about pneumococcal pneumonia, Haemophilus influenzae pneumonia, staphylococcal pneumonia, then other gram-negative bacilli which are causing pneumonia and rare causes of bacterial pneumonia. Based on the area of the lungs involved and the type of the cough produced, bacterial pneumonia is classified into two categories. One is typical pneumonia and atypical pneumonia. Typical pneumonia is lobar pneumonia and atypical or interstitial pneumonia. Lobar or typical pneumonia, in this infection of the lungs parenchyma and its alveoli is seen. It is characterized by consolidation which gives a dull note on percussion and productive cough with purulent sputum. Causative agents are Streptococcus pneumoniae, H. influenzae, Staphylococcus aureus. Interstitial or atypical pneumonia occurs in the interstitial spaces of the lungs. Here cough is characteristically non-productive and mostly it is caused by bacteria like Mycoplasma, Chlamydia, Legionella species. Then clinical characters are fever with chills or sweat, tachycardia, increased respiratory rate, dyspnea, pleuritic chest pain, then gastrointestinal symptoms like nausea, vomiting or diarrhea, fatigue, headache, myalgia, arthralgia. Yes, come. Severely ill patients, septic shock and multi-organ failure. Then pneumococcal pneumonia. It is caused by Streptococcus pneumoniae, which is commonly referred to as pneumococcus. Leading cause of lobar pneumonia, otitis media in children and meningitis in the adults. They are alpha hemolytic and present as commensals in the human upper respiratory tract. So what is the difference between Streptococcus pneumoniae and viridans streptococci? Streptococcus pneumoniae are gram-positive cocci in pairs and their shapes is lanceolate shaped. This is the typical morphology of Streptococcus pneumoniae. Whereas viridans streptococci, they are gram-positive cocci in long chains and their morphology is they are round to oval in shape. Then capsule is present in Streptococcus pneumoniae and it is, close the door. And on blood agar, Rotsman or carom coin colony shape is seen in case of Streptococcus pneumoniae. Whereas minute colonies, tiny colonies are seen on viridans streptococci. Then bile solubility test is positive or it is soluble in bile. Streptococcus pneumoniae is soluble in bile. Whereas viridans streptococci is insoluble in bile. Inulin fermentation is seen in pneumonia and optogen sensitivity is also seen in Streptococcus pneumoniae. Then virulence factors and pathogenesis. Capsular polysaccharide, it is the principal virulence factor which protects the cocci from phagocytosis and typing of the pneumococci based on capsular polysaccharide is done for identification. Then C carbohydrate antigen, that is C polysaccharide, it precipitates with the C-reactive protein, which is a marker of acute inflammation and it is raised in many acute inflammatory conditions. Then other virulence factors like pneumolysins, autolysins are also present. Autolysins, the enzymes like amidase enzyme that cleaves its own peptidoglycan and causes the autolysis of cells responsible for bile solubility and Rotsman appearance. Other virulence factors are pneumococcal surface proteins like PSP-A, PSP-C and IgA protease. These are the virulence factors of Streptococcus pneumoniae. It normally colonizes the human nasopharynx and spreads via the bloodstream to distant sites like brain, causing meningitis, then joint, bones and peritoneal cavity or even spreads locally to cause otitis media or pneumonia. Lobar pneumonia, empyema, parapneumonic effusion, invasive pneumococcal disease and non-invasive manifestations are seen. Then invasive pneumococcal disease. In this, infection is confirmed by isolation of the pneumococci from the normally sterile site. Then bloodstream infection can also be seen in this case. Pyogenic meningitis, if it is spread into the meninges, and in all ages it is seen, and others are like I told you earlier also, if bones are involved, osteomyelitis, septic arthritis, endocarditis or pericarditis, all these infestations can occur. Then sources, upper respiratory tract of the carriers. It resides in the upper respiratory tract of the carriers, and carriers are often less patients. They are not the patients, they are mostly healthcare workers. Carrier rate up to age of 5 years, then 70 to 90% of the children, they also carry this into their nasopharynx. Mode of transmission is inhalation of the droplet nuclei. Infection usually leads to colonization and carrier state. Disease only results when the host resistance is lowered or there are any presence of any associated risk factors. Then what are the risk factors? Like children who are less than 2 years of age, splenectomy, sickle cell disease, other hemoglobinopathies, then underlying comorbid diseases like chronic lung, heart, kidney disease, liver disease, cochlear implant patients, diabetic patients and immunosuppressed patients, then viral upper URI cases. Then infecting serotypes. Most common serotype is 6 and 19F. In India, 1, 6 and 19A and 19F are the causative agents. It is most commonly seen in the children. 7 serotypes like 1, 5, 6A, 6B, 14, 19F and 23F, these are commonly seen in children. Then how do we proceed for lab diagnosis? Specimen, CSF, sputum or pleural fluid can be collected. Then on direct microscopy you will see lanceolate shaped cocci in pairs with capsule. You can make out for the capsule also. It is typical appearance of Streptococcus pneumoniae or pneumococcus. Then in CSF by latex agglutination we can identify, then C antigen detection in urine and CSF by rapid diagnostic test. Then culture blood agar. On blood agar it gives Draughtsman or carom coin appearance in the blood agar. Then on chocolate agar it produces greenish discoloration or bleaching effect. Alpha hemolytic colonies are seen here. Bleaching effect on chocolate agar. Bile solubility test is positive in case of Streptococcus pneumoniae. Then earlier we used to do Coulomb's reaction test. So when we add the antiserum, then swollen capsule would be visible. So it is known as Coulomb's reaction. Then automated methods like Malditoff and Vitek. Serotyping by Coulomb's reaction or latex agglutination test is done. Molecular methods like multiplex PCR, this all you know. Non-specific findings, acute phase reactant proteins are increased like CRP, procalcitonin, these are increased in the patient. Then antimicrobial susceptibility testing is done. Treatment is oral therapy with amoxicillin for 5 days, which is a standard treatment. For meningitis, as mortality is very high, then treatment is initiated as early as possible, and ceftriaxone or cefotaxime plus vancomycin for 10 to 14 days is drug of choice. Other invasive infections for stable children, penicillin, cefotaxime or ceftriaxone, and in case of critically ill children, treatment is same as that of meningitis. Then otitis media, oral amoxicillin for 7 to 10 days. Then what is MDR pneumococcus? It is resistant to drugs like penicillin, erythromycin, tetracycline, clindamycin and sulfonamide. Serotype 19A, it is the most MDR pneumococcus organism. which exhibits the multi-drug resistance. Then you should know about pneumococcal vaccine. Pneumococcal vaccines are now added in the national immunization schedule also. Mainly there are two types like PPSV23 and PCV13. This 23-valent pneumococcal polysaccharide vaccine is also known as Pneumovax 23 and other is Prevnar 13. Then serotypes included are contains 23 serotypes as it is depicted in its name, and PCV13 contains 13 serotypes and it is conjugated with diphtheria toxoid. It covers 70 to 80% of invasive serotypes in adults, Pneumovax 23, and Prevnar 13 covers only 30 to 40% of the invasive serotypes. Pneumovax is less immunogenic, however, Prevnar 13 is more immunogenic. The protein conjugate acts as adjuvant and increases the immunogenicity of the capsular antigen. Hence, Prevnar 13 is effective against the children in less than 2 years of age. It is included in our schedule. It provides short-term immunity. However, Prevnar 13 provides longer immunity. Prevnar 13 is more expensive. This Pneumovax is less expensive. Then Haemophilus influenzae causing pneumonia. Haemophilus influenzae, its name is misnomer. It doesn't cause influenza, however it causes pneumonia. Haemophilus influenzae is oxidase positive capsulated pleomorphic gram-negative bacilli. It requires special growth factors present in the blood like factor X and V. Important species are H. influenzae, H. ducreyi, H. aegypticus. Then H. hemolyticus and parahemolyticus, which are commensals in the throat or mouth. Then H. parainfluenzae, which causes infective endocarditis. These are the few species of H. Haemophilus. It is also called Pfeiffer's bacillus. P is silent in this after the name of the discoverer. Then species name was coined wrongly, thinking that it would cause human influenza, which is actually a viral disease caused by influenza virus. Virulence factors here also capsular polysaccharide, and other virulence factors include bacterial endotoxin, outer membrane proteins, IgA1 proteases, pili and other adhesin proteins. Based on capsular polysaccharide, H. influenzae can be typed into 6 serotypes. A to F serotype. Serotype B is the most virulent among all types and accounts for most of the invasive infections. Then HIP capsule, it is unique chemical structure made up of polyribosyl ribitol phosphate PRP antigen. It is strongly immunogenic and induces IgG, IgM and IgA antibodies, which are bactericidal, opsonic and protective in nature. Clinical manifestations of HIB are central nervous system infections, epiglottitis, community acquired bacterial pneumonia, parameningel focus. Clinical manifestations, less common invasive conditions include cellulitis of the neck, head region, osteomyelitis, pericarditis, empyema, bronchiectasis, orbital cellulitis, endophthalmitis, urinary tract infection, bacteremia without an unidentifiable focus. Then the non-typable H. influenzae strains cause childhood otitis media, exacerbation of COPD, then pneumonia in adults with underlying COPD, perfural sepsis and neonatal bacteremia, sinusitis in adults and children, invasive infections. So these are the differences between type B and non-typable strains. Type B, as I already told, it commonly affects children, whereas non-typable strain affects the adults. Then HIB vaccine is available in case of children. What is the schedule of HIB vaccine? H. influenzae is a human pathogen and it is spread by droplet inhalation. Age less than 5 years of age and more than 65 years of age are mostly involved. Risk factors are household contacts, daycare center, asthenia, socioeconomic conditions, genetic differences in the patient. Then specimens are sputum, blood, CSF. They have to be processed immediately. CSF sample is never refrigerated. It has to be processed immediately, or if you have to store it, you have to store it at room temperature only. Direct examination, pleomorphic, gram-negative cocobacilli are seen on gram staining. Capsular detection can be done by Coulomb's reaction, antigen detection by latex agglutination test, direct immunofluorescence or ELISA. Culture on blood agar. On blood agar with Staph aureus streak, it shows satellitism, and other agars are chocolate agar, Fildes agar, and Levensel's agar. What is satellitism? Identification is done by biochemical tests such as DISC test for X and V factor. Automated systems like MALDI-TOF and Vitex. Typing methods such as biotyping, serotyping is done. Lab diagnosis, molecular methods like multiplex PCR, detecting common agents of pyogenic meningitis in CSF, antimicrobial susceptibility testing is done. Then what is satellitism? When Staph aureus is streaked across the blood agar plate perpendicular to H. influenzae streak line, then factor 5 is released from Staph aureus. Therefore, it forms larger colonies adjacent to the Staph aureus streak, and size of the colonies decreases gradually away from the Staph aureus streak. This phenomena is called satellitism. This is the phenomena. In the center, you can see Staph aureus streak line. Colonies of H. influenzae, they are bigger near the streak line because of the presence of factor 5. Treatment for invasive infections, ceftriaxone, cefotaxime, it is a drug of choice. Alternatively, ampicillin, chloramphenicol may be used. Then schedule for immunization under the National Immunization Program. Hib vaccine is given in combination with DPT, hepatitis B as pentavalent vaccine at 6, 10 and 14 weeks of the baby after birth through IM route at anterolateral side of the mid-thigh. Protection, it provides more than 95% protection of the infant. Develop the protective antibody levels after 2 to 3 doses of the vaccine. Prophylaxis through oral rifampin, which is a drug of choice. It is indicated in household contacts, healthcare workers. Then other causes like staphylococcal pneumonia. It is a causative agent for infant pneumonia and presents with dyspnea, fever, respiratory failure, and diagnosis is done through X-ray. Pneumatocele, thin-walled cavities are seen on the X-ray. Complications are pneumothorax, empyema, and in adults it can cause ventilator-associated pneumonia, post-viral community-acquired pneumonia, and community-acquired MRSA infections. Then other gram-negative bacilli which are causing pneumonia are, all these are mostly MDR pathogens found in the hospital environment. These are grouped into non-fermenters and Enterobacteriaceae. Non-fermenters like Pseudomonas, Acinetobacter, Burkholderia, these are major causes of ventilator-associated pneumonia. And in case of Enterobacteriaceae, E. coli, Klebsiella pneumoniae, Enterobacter species are causative agents. See, Klebsiella is nowadays most commonly seen MDR pathogen in the hospitals. It is found as commensals in human intestine and saprophytes in soil. It has 3 species, pneumoniae, Oxytoca, and granulomatous. The pneumonia is further comprises of three subspecies, which is pneumonia, ozeni, and rhinoscleromatis. The pneumonia subspecies is the most pathogenic and is responsible for severe lobar pneumonia, UTI, meningitis, septicemia, then pyogenic infections like abscesses and wound infections. Frequently colonizes the oropharynx of the hospitalized patient and causes nosocomial infections in the immunocompromised patients also. In this thick production of sputum, which is mucoid in nature, and sometimes the sputum has a thin and current jelly-like appearance. Some strains can rarely cause diarrhea and have been shown to produce E. coli-like heat-stable enterotoxin. Then hypervirulent strain, which is HPKP strain, which is more virulent than classic Klebsiella pneumoniae strain and possesses several virulence factors, is most commonly encountered nowadays. Then various commonly acquired infections like pyogenic liver abscess, which is seen most commonly, which can metastatize from the liver to the distant sites like eyes, lungs, and CNS. It causes primary extrahepatic infections including bacteremia, pneumonia, and others. Then identification of this hypermucoid strain can be done visually also. A viscous string is formed when the loop is used to stretch the colony on a agar plate. This is a McConkey's agar showing hypermucoid strains of Klebsiella pneumoniae. Then it is lactose fermenting colony. The bacteria is non-motile and capsulated. Specimens: sputum, endotracheal aspirate, ET aspirate, then urine sample. In case of UTI cases, blood and exudate specimens can be taken for diagnosis. Then on gram staining, short plump bacteria which are gram negative, and they might give appearance, sometimes they might give appearance of cocobacillary forms also. However, they are short, stout and thick in shape. Sometimes they also show a capsular halo around it. On McConkey's agar, it produces dome-shaped mucoid colonies, sticky in nature, pink in color due to lactose fermentation. Then biochemical test: catalase positive, oxidase is negative. Then your indole test is negative, citrate is positive, urease test is positive, TSI shows acid by acid, gas production is seen, however H2S production is not seen. These MDR Klebsiella pneumoniae are started with treatment with higher spectrum antimicrobial therapy. Carbapenems, amikacins or beta-lactams, these are used in case. And polymyxins or tigecycline is also used. Then it is intrinsically resistant to ampicillin and ticarcillin. Other resistance mechanisms for Klebsiella which are seen are ESBL production, then carbapenem resistance by production of New Delhi beta-lactamase, then KPC, Klebsiella pneumoniae carbapenemase. Then Enterobacter species are also involved for pneumonia. Then one gram-negative bacteria which is pigmented, which belongs to a pigmented group, is known as Serratia marcescens. It produces red, non-diffusible pigment which is known as prodigiosin. This is a pigmented bacteria and it gives color on growth. It gives color on McConkey's agar also. It is reddish in color. Whoever is not interested can go, can leave now. Non-pigmented group, it is reported in various healthcare-associated infections, lobar pneumonia, meningitis, endocarditis, septicemia, urinary and wound infection. Then rare causes of bacterial pneumonia like nocardia, actinomyces, streptococcus pyogenes, streptococcus agalactiae and corynebacterium diphtheria. Thank you.